good partner of mine, a good friend of mine, Clark Johnson, for these over the last several months due to schedule issues. So again, Clark, I appreciate all the work that you did to support this education for our healthcare leaders.
Anytime, John.
And if they overwhelmingly in chat say, can we have Clark back? I'm sorry, Clark, you'll just have to take it over from me.
I see how that is now.
See that? See that? All right, everybody. For those of you who don't know me, my name is Sean Paul. I'm the Vice President of Enterprise Healthcare Support Services, supporting all of you, not just enterprise accounts, in healthcare expertise, training, compliance, processes, process improvements, whatever it might be. So as always, if you need something, please reach out. One of the things we try to do with this monthly training is provide information that we have learned, whether it's through attending a conference or learned by being on site or learned by receiving multiple questions about pain points, and how do we share those across the organization, across all accounts in healthcare. And so you all know we have approximately just over 1,700 hospitals under Allied Universal. So there's a lot of collaboration that can be going on to support you. If you feel like you are working in isolation, you're working in a silo, please reach out, because we should be working together as peers to share best practices. And if you have a best practice, bring it forward to us and say, hey, Sean, why don't you highlight this during your monthly leadership, or can you send this out to everybody, because this is really working for us and it used to be a pain point. So let's get going. This will be recorded. Everybody, all the previous ones, we're going on over 2 years now of these sessions. And there's many times when somebody says, hey, do you have a process for contraband? Hey, do you have a process for metal detection? Do you have a process for leadership traits? I refer them right back to these links on, if you go here to applications, go to departments, click on vertical markets, click on healthcare, training, leadership development, they're all there. And they're recorded, so you can have a little more context, but there's also the PowerPoint presentation as well. And if you want some of that information to support a conversation with your client, then just ask us, and we can be part.
You put yourself on mute, Sean.
Sean, you muted.
Yeah, you're on mute.
Sean.
I don't think you can hear us.
Sean, you're on mute.
I was on mute that whole time?
Yeah.
Not the whole time, but majority, yeah.
Wow. I had a good spiel too. All right. How's that? You can see my presentation?
Yes, sir.
I remember going to.
Can you hear me?
Yes. Yeah, we can hear you.
Okay. All right. What I was explaining is where you can find all these trainings. There's over 2 years worth for you to refer to, and it's really become a library of some really good information. So if you have some question on any of that, just please reach out. Okay. Today we're going to talk about, sadly, there was a recent event in our organization. Please keep in mind when I cover current events, if you have more information than I do on this event, I'm intentionally leaving information out for privacy. Privacy of the leadership team, privacy of the organization, privacy of the people involved. So I also try to turn it into a learning point. So we did have an Allied Universal security professional who diverted some narcotics and ended up passing away. And we'll also talk about some of the best practices to help prevent that. We're going to look at and show you some of the resources from the International Association of Healthcare Safety Security that we attended, that some people attended, and show you how to access all those presentations. We're also going to talk about one of the things that was highlighted in one of those presentations was interactions with law enforcement and some of the best practices for doing that. I'm also going to talk about something that's critical, and we're going to try to help build this. It's not ready yet, but a law enforcement toolkit book that says these are the things you should already know, you should already have in place. We'll talk a little bit more about that. And then lessons learned from the Dartmouth Hitchcock Medical Center shooting. And are you ready? A lot of people left that presentation like, oh man, we have all these gaps. So I also realized this. We are not the end decision makers with our clients and that their organizations and their policy and procedures, right? But who we are is we are the security experts in healthcare to bring gaps forward to them that we should be addressing. And here's some material to help fill those gaps. If you don't have a good system for dealing with diversion and securing contraband and drugs, we can provide them with that. And we should be saying, hey, I have a concern. We don't have a good process for this. There's a lot of questions around it. Here's some things that I can help contribute that maybe will help fill that gap with the organization. Same thing with active shooters. You're going to get a lot of lessons learned from this. And are these gaps that the organization has that you're working for that we can help present ideas of how to fill those gaps? So this is one of those places we gain that information. Okay, so the safety moment. Sadly, an employee confiscated some narcotics that was from a contraband bin. They used the narcotics and they overdosed in a restroom on site at the hospital. They found him, they revived him, was in critical condition in the ICU, taken off the vent, and sadly passed away. So what is your process? What are your procedures? What are your clients' procedures for dealing with contraband, dealing with the disposal of or the waste of contraband or narcotics or prescription pills so people can't get into them? Now, back in January, so if you need to go back to get the full details of some plans, go back to the January's presentation, and there's a full list of best practices, opportunities for you to improve the program if you have these gaps. But this is why we need to identify these gaps, and this is why we need to find answers to closing those gaps, because it's serious. People can get hurt. They can be used, they can be sold to others, or they can be used and also, hurt our own staff as well. So what are you doing? What do you have in place to help prevent this from happening? Some considerations for prescription pills. There's amnesty boxes. Law enforcement doesn't always come and get this stuff unless you want to charge somebody, unless you need additional information or additional help. They don't have the resources to do that. So how are we, or how is the organization, how is our client destroying this? I worked with Josh Warden, who's one of our portfolio managers over Providence, and they insisted that we do it. How do we do it safely? And we came up with a great policy procedure for doing that and doing it safely, doing it securely. As you can see, we in that recommended the doTERRA deactivation boxes or bags. Essentially what those are is, let's say you have cocaine, let's say you have fentanyl, whatever it might be, loose prescription pills. You 2-to-1, you have two officers, you have a supervisor, whoever it might be, maybe it's even a clinical partner, and you essentially put the pills, you put the powder, whatever it is in this bag, you seal it and you shake it, and it's deactivated. It's no longer dangerous, and then you throw it in the trash. Of course, all that needs to be documented, all that needs to be witnessed and signed off that that's what you did. But this is a great tool that I've used in several locations when I was a manager. Also, in confiscating narcotics, contraband, illicit drugs, we need to have two officers. We need to have a witness. We need to have signatures. We need to have amounts. We need to have photos if possible. It needs to be documented. It needs to be secured in a secured location, and or it needs to be disposed of safely. You guys have your partners within the healthcare organizations you work with. You have pharmacy safety officers who are responsible for the destruction of these things, who can help you with that process. Part of your environment of care, part of Joint Commission, part of DNV is safely handling these things. So great healthcare partners to help you put these things together. When we designed these for Providence, we were truly engaged with them the whole time. So make sure you're taking a moment to know what that process is, and don't just say, "Oh yeah, we have a process." What is a process? Not only do you know what it is, but do your security professionals know what it is as well? And then make sure we're connected with our clinical partners. There are within the IHSS guidelines, best practices. This document is on our SharePoint site. Specific areas, section 7, pharmacy. This talks about drug diversion, and it puts a lot of responsibility on the organization that we're working with, right? Because it's their internal processes from all the way from theft, documentation, dosage diversion, waste removal, to the core elements for such a team should include administrative. See, these are the things you can bring to your client if you see these gaps of these are the guidelines from IHSS. These are some things we should be looking at improving our process. It goes on to talk about physician staff involved. It goes on to talk about properly writing the policy and documenting. So all this is just great information here in reference to dealing with drug diversion and safely and securing and or destroying those things. So unfortunately, we don't have what happened take place again. So I'll pause there for a minute. Is there any questions about drug diversion, about contraband? Again, in reference to contraband, if you go back to the January presentation, a very in-depth presentation specific to this. And of course, any concerns or whatever, reach out to us. I'll take a pause there. Anybody raise their hand or any questions in the chat, or just go ahead and take yourself off mute. Any questions or concerns? Okay. High risk, low frequency. Those are things we should be training and identifying. Okay, so for those of us who did go to the International Association of Healthcare Safety Security Conference this year, there were some really good presentations, always excellent collaboration with our peers. We do here at this link, keep in mind this presentation is available to you on the SharePoint site under healthcare. If you click on this, it takes you right to that SharePoint site, right to all of the presentations for 2023, 2024, all right here. And for an example, this is the one where I'm going to be using the debriefing lessons and learned for the Dartmouth shooting. There's also things in here of talking with healthcare, benchmarking, identifying and trending, prevention of discrimination behaviors, incident management, litigation, and healthcare security. There's a plethora of information here. And I want to just put a couple people on the spot. One, Rachel Turner, I saw that you are on the call. I know you were obviously at the conference, but you're also new to the organization. So could you please introduce yourself, Rachel? Totally putting you on the spot. And what you do for the organization and what you thought of the conference coming from a different lens of being a previous vendor of Vistalar. Maybe not.
I am so sorry. My little one had a situation. Can you repeat the last question?
Yes, I'm sorry. I'm talking about IHSS. Trying to just for people who haven't been there, what was your experience coming from the AUS side this time? What's your comments, your suggestions, recommendations about IHSS for the rest of the team that couldn't make it to the event?
Yeah, so they have a lot of resources, but not only the resources that they provide for us throughout the year, but also the networking. So I have learned so much from the other vendors, other hospital systems that are coming to that event, and being able to figure out, tips and tricks that I can share with a hospital that's in North Carolina that comes out of Texas, and just having that collaboration has been absolutely fantastic.
Yeah, great. Thank you, Rachel. And I did say that you are newer to the organization. Do you want to just introduce yourself and what your role is to this group?
Yeah, absolutely. So I am now the regional director for healthcare for the Southeast region. I came from Vistalar, I was the national director for their sales. So I'm very familiar with Allied. I was very excited to join the team, moved from doing the training side to actually doing the guarding. So I'm super excited to be here.
Yeah, thanks, Rachel. I'm going to try to put one more person on the spot. Robert Matera. He's one of our site managers for Duke Health University. Robert, it was your first time to the conference. What was your, as a first time, as people prioritizing this for maybe the next year with their leadership, what was your experience and what would be your recommendation moving forward to your peers on the call? No? Okay. How about Brandon? Brandon, I know you're on and this was your first event. What's your thoughts and recommendations for your teams trying to prioritize this in the future with your clients and your general managers?
Yeah, for me, Sean, can you hear me? Make sure I'm not
Yes,
still on
sir.
mute. Yeah,
Yep.
for me, I mean, like Rachel alluded to, the networking was one thing. I think just the overall need to continue to grow and develop our strategies to keep the technology up to date. There was a lot of cool technology that I saw. I'm big into tech. And just overall preparedness for us as security. I think one of the stats was by 2028 they expect healthcare to grow like 70% more than where we're at today. So it's huge opportunity for us as a company. But even more so when you think about renewing your contracts, you have to know what's out there, what exists today that we can implement to keep our hospital here that much more safe, help us to do our job a little bit better. So it was really cool to witness that firsthand. It was my first time, so I'm looking forward to getting back out there.
Yeah, thanks, Brandon. I appreciate that. And for those of you who have not been, for those of you who have difficulties getting support for it, IHSS has a document of gaining support from your leadership team. I also worked with your peers, Darren and Andrew from Memorial Care out in Long Beach. Last year and now this year, they both got to go with their leadership and the value of it. So we can help you have those conversations as well and build a case for why you should be attending and more involved in this association. So moving forward, if you need any of that assistance, please, I really think it's well worth your time. I think the certifications are worth your time. Meeting with the vendors and seeing what new trends are worth your time, and definitely collaborating with your peers in healthcare is well worth your time. Anybody else who attended the conference who has any comments? Quiet group today. All right. So interactions with law enforcement. I've been in healthcare for 13 plus years now. Retired law enforcement officer. There was this great tool that they suggested, and it's called the Law Enforcement Toolkit. So as I go through some of these items, think about this. If law enforcement shows up and wants to use body cameras and turn them on, what have we discussed beforehand with AUS legal, with I'm going to use it because I already said the name, Duke University Health System, with their clinical team, their safety officer, their privacy officer, and have a pre-conversation, a pre-policy that the staff is aware of law enforcement coming in with body cams and how we handle that. What about when a law enforcement officer comes in and they've been shot and their handgun is turned over to us until their partners get there to take over that handgun? What do we do with it? What do we do if an off-duty law enforcement officer shows up and they have a concealed weapon on them? What do we do with that? Now, if you tell me they can't take it in, okay, then where are they going to put it? They don't have their car. How do we secure it? Or they can take it in. Do we know that? Is that policy? Is that procedure? What if they come in and they want a blood draw and the person's refusing to give the blood draw? So that was another tool in this toolkit. So we identified all of the different things law enforcement might need, might ask for. If you all recall, I think it was in Colorado where the nurse was arrested for not doing a blood draw on a driver who was not the cause of a crash, and she refused to do it and got arrested. So that's where this came from, is preparing us for these law enforcement interactions. So it's a collaborative conversation. We've already met and collaborated with law enforcement, met and collaborated with AUS Legal, met and collaborated with the organization we're representing with, to know the answer to these things so we don't run into these roadblocks. So obviously these relationships are critical. We need to have continuous conversations with them. Essentially, if we can do face-to-face meetings, if we can have the conversations, get to know each other, build rapport, absolutely. We need to share perspectives. They're coming in and looking at everything as a criminal event. We need to help to explain to them that we are there, our healthcare providers are there to protect the patient's rights, to protect our rights. Therefore, how do we, I want to say, combine those and balance those so we have a good conversation. I'm telling you, this meeting quarterly or semi-annually with law enforcement leadership, that should be not only someone from the command staff, one of the street supervisors, a sergeant, a lieutenant, and then one of the officers, the ones who are coming in and out of the hospitals. So if you can make that connection, if you can set up some regular meetings to share some of these pain points and to try to flesh them out before they come up, it goes a long way. Weapon screening. What do you do with weapon screening, right? So this was a great thing that they had in the toolkit, and they answered those conversations. One, weapon screening's been introduced on a risk-based approach. We looked at the CAP index. We looked at our different calls. We looked at the size of our hospital. Therefore, the client has made the decision to implement screening. But what do we do with concealed carry permits? I know you say we don't let them in, but maybe they're being brought in on a stretcher and we need to secure that weapon. How do we secure it? Maybe it's off-duty law enforcement in good standing. Are they allowed to have their weapon or not? Is that clearly identified in your policy? So make sure these things are being answered. Body-worn cameras. I brought this up. Keep in mind, this is not a broad sweeping across the country answer of whether or not they can be worn and are used or activated, or when should they be activated. There's city, municipal, county, state, province, territory, whatever laws around this, and filming and notifying. So, if we are doing that, like we have video surveillance, are we notifying people? Do we have to notify people? If we are wearing body cams because we have tasers, do we need to notify you are on video? When can we use them? How are they stored? How are they safely stored? How long should the video be stored? All these things, if you're using them and not answering these questions up front, you're going to get yourself in a little pickle. Patient privacy. This is huge, and this is where law enforcement, we tend to have a conflict with, of them clearly understanding HIPAA. We focus on protecting the patient privacy, patient autonomy, while they are focused on essentially pursuing justice, pursuing the law, the violation, making arrest or making a citation, or even just gathering information. And sometimes them timely gathering information interferes with our ability to support care, our clinical partners delivering care. So there's a balance there. Some of the privacy regulations, you're all aware of HIPAA. You should be aware of HIPAA, but there's also some local and state civil codes as well. So make sure you're researching those. And obviously, I don't have an answer for you in all those. I can help you find them because they're different for each state, sometimes different for each county and location. I'm always told, but when can we let law enforcement know when somebody is here? Typically, it takes a subpoena. Typically, I refer them to HR or the privacy officer and allow them to deal with that. That's not a security issue at that point. That is an administrative issue with the hospital. And what's their process for releasing patient identity or whereabouts if they have a warrant? Typically, you can allow them to know the date. So on 5/21, Sean Paul was here at 1:30 p.m. And we know it's Sean Paul on the right Sean Paul because this is his date of birth. That's essentially all you can give to law enforcement unless they have a subpoena. So make sure you're aware of this. Again, this should be in your law enforcement toolkit because we're also not always there. And what's that nighttime supervisor do at 3 a.m. when law enforcement comes in? So essentially, whenever possible, interact in pairs. Why? You have a better conversation. You have a witness of what took place. You can support each other. Not one person always has all the answers. We need to remain calm and professional. Sometimes we get a little antsy around law enforcement. We get a little bit worked up about law enforcement. They start to get defensive. We start to get defensive. Make sure you know who you're working with. What's the officer's name, badge? Do they have a business card? And if possible, what's the case number they're working on? Because that's how, when we call back and we need to give information or get information, that's how we do that. Introduce ourselves. Hi, I'm Sean Paul with Allied Universal. I'm the site supervisor today. How can I help you? Document the request. Document. This is where that case number comes into play as well. Pass on the document to your appropriate supervisor, to your client. I should add client in here, so that we can respond and make sure that we are facilitating that relationship. And then at the end here, I put that law enforcement toolkit. Again, we're going to try to put together as our team an outline for it to say, these are the things you should have answers for locally. And these are some things you should consider in each one. So we're going to begin to build that out and have that as a resource for you. Any questions in reference to law enforcement interactions? Any pain points that you're dealing with or any best practices to share with your peers on the call? You guys are all taking like an afternoon siesta or something.
Hey,
Brandon,
Sean,
anything?
nothing in chat. I saw, I think Bill's hand went up, but I'm going to post in chat just something to follow up to the body worn cameras and kind of some do's and don'ts according to your state. But like Sean said, it does, matter about your city as well. That does play a role in it, but it gives you an idea of what constitutes as quote unquote private. So I'll put that in the chat for you guys to look at as well. On page 6 and 7 is the state by state legislation and kind of how it is a table. So super easy to read.
Great. Thanks, Brandon. And did somebody have their hand up? Does somebody have a question or comment? All right. I will move
Sean,
along.
I'll jump in.
Yeah.
Hey, so being a law enforcement officer as well, I have dealt with the perception of law enforcement towards security, for like 36 years, and it's not a good thing. So how do we change that perception? Is by knowing the laws, knowing what we're supposed to be doing, and being able to respond correctly instead of reacting when they come on site. So, the collaboration between law enforcement and security is essential. So what we're saying is you've got to learn the laws. You've got to learn what you can and can't do. And by using these law enforcement tools or the police, toolbox, it's going to do nothing but help us in the future. And I really appreciate that.
Yeah, absolutely. I love the respond and react, right? When you're responding, you're professional, you're informed, you have information. When you react, that's when you're going to make mistakes. And that's when they see that you really don't know, you're second guessing, they're going to roll right over you. So by having all this information up front, by having conversations with law enforcement up front and getting this toolkit filled in, not only will we have the information, but our people will have the information when we're not there. How many of you, and it's usually counts that are struggling, the client goes up to that new security professional who's been there for a week and says, hey, what are you gonna do if law enforcement comes in here and they're wearing body cams? And they're like, I don't know. Well, now everybody can refer, well, here's the law enforcement toolkit. Let me flip the body cams. This is our process that we've identified with you as our client, with law enforcement as a partner, and with AUS Legal. And there's your answer. So yes, it will build confidence with your law enforcement partners. I appreciate that. Anybody else?
Frank had something, Sean.
Yeah.
Hey, Sean,
Frank?
how you doing?
Good.
Just had a quick question. When you contrast being
Yes.
at work dealing with LEOs and the SP may have had bad interaction or interactions with the LEOs offsite, how do you bridge that gap to keep the SP from being shy?
Yeah, so let me just clarify. So this is at some point the security professional has had a conversation with a law enforcement officer. It hasn't gone well, and now they're afraid to interact with law enforcement. Or are you saying that
Correct.
they've had a negative contact with law enforcement outside of work? Bad situation. They don't like law enforcement. They don't trust law enforcement. Therefore, they don't want to engage with them.
Correct.
Yeah, I think that's the getting to know each other. That's the face to face. That's having law enforcement come to maybe one of our team meetings, to shift huddle, and saying, "Hey, can you explain your processes and your procedures and what some of your concerns are when you come to the hospital? Hey, let's go down. Let me get you lunch." We always had, in some places, law enforcement officers can't take gratuities. Some can, it depends on your location. But we had a rule in one of our hospitals that all first responders get half price off lunch because we want them to come to the hospital. So how can we get to know them better? And I, as a previous law enforcement officer, I've been in classrooms, right, where little Johnny had dad taken away on Christmas, doesn't like the law enforcement officers at all. How do you sit down? How do you have conversations? And how do you build that rapport? So I think getting to know them as people, them getting to know us as people, and that's having face-to-face conversations or meetings, can really help bridge that gap.
All right. Thanks.
Yep. Anybody, anything else? All right. So, excuse me. I'm going to move down to the last subject, but I'm going to go to a different presentation. It's the presentation that was actually given at IHSS. I'm doing that for a couple reasons. One, I want the exact information from Dartmouth that they presented. Two, I want you to see the quality of, some of the presentations given at IHSS, and also to see the resources that we posted online. So let me click on this. It goes through the SharePoint. It goes specific to this presentation on this shooting that took place in Dartmouth. It was in 2017, but they're now reporting out on what some of their pain points were and what some of their lessons are learned. So you all can go back and refer to this, but essentially, wait till you see some of the gaps and the lessons learned, and I'm sure you're going to be like, oh my God, we have two different access control systems. We could have that gap. I should bring this forward as a best practice and an incident and data saying why we should have one access control system. Cameras not maintained. Geez, I don't even know the last time we had the cameras maintained. I know we have 10 of them that are out. Shoot, let me show this to the client why we should prioritize the maintenance of our camera system. So those are some of the things I'm also looking to provide you in this presentation. So let's go. All right. So here's the incident. September 2017 on an ICU unit. I know most of you have ICU units. A female, age 70, was shot and killed by a 50-year-old male. The suspect entered the north entrance, proceeded up to level 1, entered the 4 South ICU, shot and killed his mother. So a lot of times, when we're talking about active shooters, it's not strangers, like in most cases. These people are either an inside threat, an employee, and or somebody who doesn't like a physician, and or a domestic abuse or a domestic situation where somebody's dating somebody else and the spouse comes in, and or family issues as well. So those are some of the areas we want to look at. Let's see. Overview, we'll look at lessons learned from significant challenges. This was a specific targeted homicide, not an active shooter. This is an armed intruder. Initial information received and circumstances led to an incident being treated as a potential active shooter, which you're going to hear gunshots, right? I'm going to assume it's an active shooter until I hear otherwise. The response was formed in consideration of a possible active shooter or ongoing multiple threat until proven otherwise. So I keep hitting my button. So here's my question for you as I go through this. And I'm going to go through fast. One, because it's a lot of information. Two, I want to make sure you stay awake. Three, I want to identify the gaps and get to all the gaps so you can help address these within the organizations you're serving. Are you prepared for this event? And if you tell me, oh, we have run, hide, fight. Oh, we do training online. What are your policies, procedures? I'm telling you, the majority of us are not prepared for this type of event in a hospital setting. It's very complex, but this will give you the nuts and bolts of what to look at. So I kept this up here, right? Because it looks like a lot of you guys, right? Here's a location on Vermont, New Hampshire border, not an extremely busy area. Resident population, 15,000, that's small. Daytime population surges like most. Dartmouth College, so it's a university town nearby, like a lot of you. 225-acre campus, 1.2 million square foot facility, 10,000 plus staff, visitors on campus daily, academic medical center. I know a lot of you have that as well. So high profile, high risk. Just so you know, I talked about the ICU and where they're coming in from. So here's the entrance where they came in. A lot of you, I show this because you have multiple entrances. How do we control those entrances? Multiple parking lots, multiple thoroughfares, ingress, egress, and then up onto one of your floors. And this could have been any floor, right? Where mom was staying. All right, so access. They have an open campus with no weapon screening. That's many of you. 6 public entrances. That's actually not too many for a hospital. We have so many public entrances, it's crazy. Also, several employee entrances also open during the day. And even though 4 South is a secure unit, what are the gaps that allowed him to get in? Is that because he was a son of a patient and he was just able to come in and tell his name and walk in and then he brandished the weapon? Registered as a visitor after patient agreed to see him. Although estranged from his mother, she allowed him to visit in the room. Are we aware of these? This is why we round. This is why we talk to nursing. Nursing might not see this as a concern, but when we hear estranged relationship, mom allowed to let him in, we should start to get the hair on the back of our neck standing up. So I show this because look at the chaos, right? The call comes in at 1:24. Look at everybody outside wondering what is going on. What is the mass communication going on? What is the notice to employees, staff, visitors? What if you're in the ED and your child's in there and now you're out here, you're not allowed to be in the hospital? Second call to 911. Now we start getting confusing information. Radio calls coming in, cops showing up, incident command, perimeter, surrounding the perimeter. It starts to get chaotic quickly. Immediate reactions, Code Silver called. For many of you, that's somebody with a weapon. Code Silver, let me ask you this. For your policies, this is something to think about. And I talked to somebody recently about this. Code Silver, somebody with a weapon. Code Silver, active shooter, somebody actually engaged in killing. Somebody pulls out a baseball bat, Code Silver. Somebody pulls out a knife. Somebody grabs a needle off bedside and they're threatening people with it. Or somebody actively shooting people or slashing people with a knife. 2 different situations. Do you want people run, hiding, fighting? Do you want people not going to the area? Do you want people going to the area because it's just somebody with a bat who's threatening to use the bat? Think about how we can clarify what a Code Silver is, therefore clarifying the need to respond or not. Former training here was run, hide, fight. Significant others of patients and visitors and staff self-evacuate through the entrances. Now, how is there command and control of that? How do you communicate that it's all clear or not all clear? Where do they go for assistance? In some areas of the hospital, we're able to lock down, but some not. Security responds to ICU 4 South, where the shooting took place. When security arrives, female victim shot and cardiac arrest. The family of the victim's present. Of course, chaotic. No shooter. No shooter on that floor, but now where is the shooter? Think about that going on in your hospital. What is your process? Who's watching the cameras? Who's watching the doors? Is anybody watching the cameras to now get a description of the suspect and to start looking for that suspect? Chaotic, right? So that's why we need to understand the policy of the procedures, and we need to be able to train to that, drill to that. Therefore, we will respond and not react. Challenges, limited security officers on duty, right? Majority of you are dealing with that. Volume of law enforcement officers responding. Local PD, county sheriffs, state. I'm telling you, if there's FBI in town, they're coming. The Marshal Service in town, they're coming. I was in a shooting as an officer, and I tell you what, all of our law enforcement buddies were there from every entity, even ones off duty who had their radio on at their house, they're there. What do you do with them all? 150 plus officers. Self-evacuations, how do you manage that? Multiple points of ingress, egress. Let me ask you this. I can't see all your reactions. I would imagine you all have a process for locking down. Do you have a process for identifying what doors are on access control and are constantly locked down 24/7, are on timers and open for business 7A, 7P, but how do we secure those in emergency, or are just a facility key? And who has keys to those doors? What about your loading dock? That's typically open all the time, people coming and going. So we say we can lock down, but what truly is the process for locking down each and every ingress egress point? We should have a list of all those, how they lock down and who's going to lock them down, and then checking them off as they are locked down. Otherwise, we do not have a secure footprint. Size and scale of the campus was an issue. Technology failures, we'll go over that. Communication limitations. These are all the things that snowball in a critical event. Come on. Unified command. Guess who's running this? It's not the hospital. It's not us. It's law enforcement. Guess who cannot open up 4 South ICU for normal business, more normal clinical care until law enforcement's done? So what is the long-term impact? What is the business continuity of that organization during a critical event like this? Lebanon police incident and tactical commanders, additional staff come in, mutual aid departments come in, fire come in, EMT come in. Fire always wants to take over command and control of the incident. You have your security director, you have your major management director. Trust me, your chief medical officer is going to be out there. Your chief executive is going to be out there. This is going to be a mess. Therefore, that's why we need to drill this. I know you guys aren't responsible for all that and making sure the organization does that. But again, you can use this tool to bring these gaps to your client of things we would like to focus on as priorities this year or next year, or this is why we want to collaborate with emergency management. Ongoing considerations during the event, still not locked down, partial lockdown. 2,000 people, including personnel, patient visitors evacuated. Evacuated to where? What about those patients that need assistance? Thousands more hospital personnel, visitors, patients sheltered in place. Who's sheltered in place and who's not? How are we communicating with them so they know what's going on? Surgeries and medical treatments still taking place. Trust me, you have a surgeon doing an open heart. You have a surgeon doing open cavity, something like that. They're not closing up. They got to finish doing what they're doing. How are we communicating with them? How are we securing their footprint? So a lot to consider. This is why we need to drill it. Homicide scene within active intensive care unit. We talked about that. What do we do with other patients? Medical providers, victims, families. Don't you think if you heard there was a shooting at the ICU at this hospital and your family's at the ICU, what are you doing now? Now you're going to the hospital. Now you want to know how your family is. So how are we dispersing information to the public that's coming in, getting information about our patients? We can't release patient information. What's the balance of patient privacy with families and outside entities during a critical incident like this? And again, they still don't know where the suspect is. High risk situation. Are they lying in wait for another shooting? Did they leave? Did they shoot and kill themselves? That's stressful, not knowing where the shooter is. Messaging, they use overhead announcement. They use Alertus, which pops up on their computers. Many people can opt in or opt out. Also on your mobile device. Oh, this is my personal device. I don't want those things. I bet you if they're hiding in a closet right now or under their desk and they have their cell phone, they wish they had this mobile opt-in. Staff email went out. Social media went out. Overhead paging. This lasted for over close to 4.5 hours. Communication is critical. Here's some issues. Where's the shooter? Number of surveillance cameras not functioning. We should be maintaining, our clients should be maintaining, facilities should be maintaining security equipment once a month. Panic buttons once a month. Security cameras once a month. Cleaned. Are they working? Focused. Do they have power after construction did a project? Monitoring systems, whatever it is, they are required to have a once a month to check. They didn't have a dispatch center. Nobody was monitoring cameras. Police needed a photo of the shooter. Security had to be escorted to the office to access the system. Security was able to obtain one photo of the suspect. Security and police began interviewing the victim's family. Of course, everybody's out looking for him. Locating the subject due to multiple cameras not functioning, security was not able to track the suspect. Oh, he goes in the stairway. We have no cameras. He goes down this hallway. The camera's out. We lost him. Now we can't track him. They have identified that he left with a firearm, so they know he still has a firearm on him. There's a picture of him, but they can't track him. Firearm in the bag. Misinformation. This always happens in these big critical calls. Suspect in 3C clinic with a knife and a hostage situation in 3T, second report of hostage in 3C, reports of individuals walking outside the campus that were possibly the shooter. Ton of information coming in. Is that coming into 911? Is that coming into a hospital line, dispatch center? You have all this misinformation. Apprehension of the shooter. The order was given to shut down the 2 roadways used to exit the hospital, trying to create a perimeter, right? Traffic was backed up in the loop, but also nobody's coming in to get medical services anymore. People aren't able to leave anymore. Stress is getting high. They ID'd the shooter. Description of the vehicle. He was found by law enforcement stopped in traffic, so he was trying to leave, but because they locked down the perimeter, they found him. Clearing of the hospital. Huge. You don't know if there's just one shooter, 2 shooters. Did they hide the weapon? Somebody else come across a weapon? Lack of adequate surveillance. Concern for additional suspects. Police needed building maps. They didn't have them. Police systematically searched for 4-person teams. Now think about patients in rooms. Think about people hiding that we can't communicate while the police are systematically searching. Limited key access. So this is big. Do you have law enforcement go bags with key access cards, maps of the building, communication with security, etc.? They should be in a place where as soon as they come on the campus, they're given a go bag and we have immediate communication. They have the resources to be successful. Post-incident, security had 2 separate access control systems. Lockdown was only activated on 1 system. Huge gap. I briefly mentioned that in the beginning. Numerous cameras not working. Caused thousands of people to run out of the building in the areas that were not secured. There were multiple points of failure in emergency notification. This is huge, right? We can't lock down. We can't see. People are going everywhere and we can't communicate. Therefore, what's our processes to help ensure this doesn't happen to us? Code language was confusing. Listen, y'all, there is a push in emergency management across the country to go to plain language. Why? One, in stressful situations, we're not paying attention. We don't hear the code. We don't understand what's going on. Plus, our visitors don't know what all the codes are. So plain language is a huge push. We have a person with a gun in ICU 4 South. Person with a gun, isn't that much more effective than Code Silver ICU 4 South? Well, what is that? If you're a visitor, if you're a family member, if you're a patient, you don't know what that means. Big push to go to plain language. Some employees not receiving the emergency notification because they opted out, multiple cameras down, very little active shooter response training. Hospital security and staff had not trained with the Lebanon PD. See all your lessons learned here? These are all things for you to meet with your client on. Process of lessons learned began immediately. Relationship with Lebanon police improved significantly, but this is all after the fact, right? We've missed the opportunity. And they were then brought in and asked to work in the emergency department. So there was law enforcement response on scene. Do we have people with the ability to respond to deadly acts? Almost done, y'all, and then we can debrief. Security created tactical maps. We talked about some lessons learned of the facility for law enforcement. Areas of the hospital were prioritized, ED, OR, etc. Fire personnel issued hospital bags. I talked about go bags for access. Critical incident kits updated with additional access badges. I would also say, where are our tourniquets? Where is our immediate access to medical supplies? Even though this is a hospital, if I'm up in a patient waiting room, if I'm in the cafeteria, if I'm in the library, if I'm in a conference room, those things are immediately available. So where's our AEDs? Where's our tourniquets? Where's our quick clot bleeding bags to be able to respond to these situations and have the ability to provide care? Lessons learned, life-saving medical procedures continue to take place during the incident. Yes, they do. Providers and clinical staff will be reporting to the hospital to relieve their colleagues and assist with medical care. Security incident command must be prepared to work with law enforcement. And during the event, getting medical staff escorted into the hospital was delayed because there was no plan of dealing with that. Ongoing partnerships played a critical role in managing this incident. Advanced Transit provides buses, services the campus. AT was pressed into services to ferry thousands of patients from the parking lots who had fled, establishing relationships before critical incident was imperative. So this is what is our mobile ability to provide treatment, right? Not our responsibility, but we need to secure the footprint. This is a good lesson learned for our client. How did they improve? They decided to move to plain language. Active shooter policy was updated. Avoid, hide, fight. Cameras were repaired and added. These aren't things you want to do after the fact, y'all. Number of cameras increased exponentially. Lockdown capability and procedures modified and improved. Coordinated training and drills involving external stakeholders. Security implemented 24/7. All these things should be proactively done. Lessons learned, Security Operations Center they opened up a new one, 24/7 dispatch. monitors cameras from across the Dartmouth Health System, provides dispatch services for security, located within the security office in a secure environment. That is a best practice, y'all. Plain language, active shooter, bomb threat, fire, abduct missing child, mass casualty. Messaging, organizational messaging during critical incident was modified for clarity and consistency. Emergency communication system improved and expanded. Alert systems were upgraded. Alertness, overhead paging, opt-in mobile. Access and surveillance. Cameras were fixed, replaced. Security moved to one access control. Access control increased throughout the hospital. Hospital considered whether to implement weapon screening, but opted not to. I think that's a failure. Other considerations, external environment, weather, water, that your organization should have a large stockpile of fresh water on hand, not only for these incidents, but what if the water system goes down within the hospital? Medical needs didn't stop. They needed a MASH unit. We talked about alternative treatment centers. All clear messages were not received by all inside the hospital. Communication, communication, communication. Reunification plan, business continuity plan. Primary and secondary IC incident command locations are both within the hospital and neither could be accessed. Where is the alternative incident command site? Is it the medical office building across the street, the conference room across the street? It cannot be in the hospital as the one and only site. They're unfamiliar with established protocol for scenarios like this. They're not drilling. They're not practicing. They're ready on paper, but that's it. We're not familiar with transferring the ICS cart from primary to secondary location. Essentially, an ICS cart, if you're not familiar with that, that stands up the incident command. That gives everybody in each position within incident command their priorities and their documentation. Therefore, that's inside the hospital. That's to go to the incident command center, but they can't use it. Therefore, where does it go to support offsite? We had a mobile one that could be used in the meantime. Alternate location was in off-campus hospital building. That's very effective. You do not have to be right on the site. Avoid versus run, over 10,000 people on campus on any given day. Given directions to run, proved to be problematic. We now train to avoid, run and leave the area, move to another area of the hospital that is more secure. This is the difference between an active shooter, and this is the difference between an armed intruder. Active shooter, where they're going around killing everybody, you need to get out. If not, you're locked, barricading, preparing to fight. Training was increased for staff with workplace violence mitigation, active shooter, de-escalation. Security began to train and collaborate with Lebanon police, active shooter drills, tabletop drills. Dartmouth network moved to evade training program for de-escalation. Again, this is all after the fact. We want to be trained beforehand, everybody. Final thoughts, continuous improvement cycle preparedness. For those of you on my team, you don't need to raise your hand or say anything. And those of you who I work closely with, our partners for Memorial Care, partners for Duke University. How many times do you hear me say continuous improvement? How do we continually improve our programs? Incident is referenced consistently as we move to improve training, preparedness, technology, people, processes, technology. We have to look at these things each and every year. And that wraps it up. So a lot of information there. I know that we're almost out of time. I want to take a pause. Any questions in reference to this presentation and this information? Anybody? Anything in chat, Brandon?
No, sir.
Anybody still on the call? All right,
Yeah, we're
everybody.
still here.
Still here. It's
still
great
We're good.
information.
Oh,
Yeah, we're
Fairness,
here.
thank you.
yeah, and if anybody needs any follow-up on any of this, please reach out. Thank you for your time. Thank you for serving in healthcare. It's not an easy specialty. Always a resource for you. Have a great day and take care.
Bye, Sean. Thank you.
Thanks,
Thanks,
Sean.
John.
Thanks, Sean. Thank you.
Happy
Have a good day,
Memorial
Sean.
Day, my friend from Northern Virginia.